Yeah, the biggest takeaway from the study is that it is feasible to support families managing severe food allergies by providing them with monthly subscriptions to allergen-free foods, like through an online portal, and have them select foods that they particularly would, feel that their child would benefit from having access to, and that does appear to have impacts on their ability to successfully manage their food allergy day to day, reduce food insecurity within these families, which were recruited due to their status as like having trouble, putting food on the table during the COVID era, and also potentially improve allergy management outcomes, like both in terms of psychosocial outcomes, like their ability to, successfully navigate social situations, as well as other aspects of just feeling empowered to prepare allergen-safe meals and stay safe, on day to day. Yeah, well, I think it's long been a known need, in the food allergy population in the U.S. like that. It's challenging to navigate just daily life, even if you have tons of resources and are living with a severe food allergy, just because food is everywhere and it's not always clear where your allergen might lurk. And so a lot of folks are very, tend to have elevated anxiety and are just stressed about like navigating certain situations. If you are on a very tight budget and don't often have access to all the latest and greatest like supports, you can imagine how that would be even more challenging. And so that was a need before the COVID pandemic. When the COVID pandemic hit, it was even more acute for a lot of patients, just because rates of food insecurity continued to go up. And so this was when I was at Stanford University as a postdoc. Like we were able to get some funding to explore the feasibility of doing this pilot study where we supported the families in, trying to fill some of those gaps in terms of access to foods that they trust are safe and are likely to be, palatable to their child, and allow the families to better accommodate, in the day-to-day, the particular allergies. So you're not faced with like buying, spending the same fixed food budget where a disproportionate amount of it is going to accommodate the allergy and less is going to like feed the rest of the family. We thought, can we provide more support so that choice doesn't need to be made? You can actually have the foods to support management on the day-to-day for the child with food allergy, and also, provide enough, good food for the rest of the family. So that was the goal. Of course, the challenge is that this was just a small pilot study. We had remarkably high rates of dropout. It wasn't easy to recruit participants into this study, surprisingly enough. And it wasn't easy to retain participants to this study, even when you might imagine it would be very attractive to be presented with the option of, here, get $155 worth of free food every week, get a CSA basket of fresh fruit like shipped to your door. All you need to do is fill out some surveys. But it was challenging to actually successfully, communicate that really was the expectation, and that was the nature of the study, and really all we wanted to do was explore the feasibility of doing that and understanding what the effects are. So, one obvious lesson learned and remaining gap is that this was just a tiny study. It's a drop in the bucket compared to the need, and these sorts of interventions are kind of hard to scale up, because if each participant requires a lot of hand-holding to like navigate the process of, initiating their food orders and, coordinating, month to month, it might not be something that can be deployed at scale, at least kind of with the current system. So we're trying to keep refining the systems and figure out how we might be able to implement it in a more cost-effective, like just broader way. So that's sort of the next step of this research. So this was a multi-site collaboration between Stanford University School of Medicine, Northwestern University Feinberg School of Medicine's Center for Food Allergy and Asthma Research, which is where I am currently assistant professor, Kansas City, or University of Kansas Health System, and University of Texas, Texas Children's Hospital, Baylor University. So it was, we all coordinated and did a different version of this intervention, but made sure to assess the same, outcomes. And we all together, enrolled like 60 participants in this trial that lasted 6 to 9 months, depending on the site. Yeah, I think they hold a lot of promise. I sort of, I grapple with the idea of like food as medicine when like food should also just be food. Like it is, it's a sad state of affairs when so many families need to make these decisions between like putting not just food on the table, but like the right kind of food on the table that both keeps families safe and also is healthy and eaten by these kids, because some of these kids are young, and I have a young child, and just because you've got the perfect thing on the table doesn't mean they're going to eat it and they're going to get the nutrition out of it, so that aspect of things is challenging. I think there were positive signals that the intervention had its intended effects, but we need to do this at such a larger scale and figure out a way to do it in a cost-effective way that is covered by payers, commensurate with the outcomes and cost savings that it's achieving, at the broader like health system level. If we can reduce, one or two hospitalizations due to food or accidental food exposure or ED visits or missed work, those savings add up. It's hard to actually calculate that, but I think it's really incumbent on us as the next step of this work to really try to quantify, what's the actual economic impact in, with respect to these interventions, so that we can, make the argument that, hey, it may cost a little more to provide these foods and these interventions to families, but it's going to be cost effective in the long run. And also it's going to obviously improve the lived experience of these families, which is super important. So that's sort of where it stands right now. Yeah, I think so. The one big thing is that we had very high rates of attrition. It was these families, by their nature, because we recruited families at high risk of food insecurity, not necessarily from allergy clinics, but also from like federally qualified health centers that were, affiliated with the universities that we were all at the time. These families have a lot going on. There's a lot of precarity in terms of like housing precarity. Like, they might be moving. They are dealing with other kids in the family who have chronic disease, and so there's a lot of competing priorities for time and resources. And so we didn't really. And we also at Stanford, we recruited almost a huge majority of our patients were Spanish-speaking, like recent immigrant populations who had other challenges we hadn't anticipated in terms of even like digital literacy with the ordering platform. Like the idea of checking out like a virtual shopping cart was not, like online shopping was not something that many of these families had any prior experience with, and so that led to more barriers to participation long-term and retention in the study. So I think part of the reason that our findings, didn't show, we weren't well powered to find statistical significance is because of the high rates of dropout in our sample, which I think now we understand things we can do to try to reduce that in the future. But at the time, we're sort of stuck with the data we have. The other thing is it was an uncontrolled study, so even if we showed statistical improvements, it's still important to show that this is better than, not getting the intervention. And so that, we didn't think it was ethical at the time to have a control group where folks wouldn't, get the intervention because we were just wanted to show that this was feasible and potentially beneficial. So that's part of the reason as well. So I think future work would need to be, much better powered. So like larger studies with like sensitive outcomes. And now we understand what some of those might be. And then also just really, put systems in place to make sure that families are supported like through the whole study in a way where we ensure low dropout, and that could really help. I think those are good lessons for like any study, but particularly studies like this. Yeah, just that we need a lot more work in this space, and I think it's also there's a lot of work in food as medicine interventions in different disease states that's sort of happening independently. There's people like trying to do food as medicine for diabetes management, food as medicine for food allergy management, food as medicine for, maybe cancer prevention, celiac disease. And I think we need to think more about how can we implement more standardized interventions across more sites, across more disease populations, so that we, can build the evidence base sort of broadly, because I think having access to safe, healthy foods is likely to bear fruit in all sorts of health outcomes, not just like reduction in anaphylaxis rates or, food allergy related self-efficacy. So I think we need to, and that's part of why it's great to be at this conference and like connecting with people who are, working in other diseases, other immune-mediated diseases, to try to figure out how we can collaborate more and sort of all join forces to kind of be more efficient and more impactful. This is a team at Stanford, University of Kansas Health System, Texas Children's, Baylor University, Lurie Children's Hospital, and Northwestern University Center for Food Allergy and Asthma Research. It's a big team of people who really care, and I'm just happy to be a part of it.